Andrea is a specialist in anesthesiologist, intensive care, and emergency medicine. She is also an emerging psychotherapist and one of the most gifted psychotherapists that I have met in my life. I'm not talking about relationship quality here. So I'll give it to you, Andrea. Take it from here, please.
Yes. Good morning. Can you hear me well?
Bring it a little bit closer to your mouth.
Does it work now?
Sure.
Muss man gerade tauschen oder?
Ah ja, vielen Dank.
So, is this better? Okay, I just go for it. Right, so do it this way. Good morning, everybody. So we've almost spent the entire time of the conference together now, and I think we had a banquet of different opportunities to learn about basic science, therapy, get the impression from many, many people. And since you all are most possibly full with information, I'm not going to throw another big bag of data on you. I would like to help you perhaps pack a lunchbox of ideas to take home with you. And the topic I've chosen, and interestingly enough, the main point has been shifting through the conference for myself, is reinventing the wheel. And it's a bit of a provocative question because, okay, of course we are with psychedelic therapy trying to reinvent the wheel of therapy and most possibly care in existential situations. But let's have a look at this a bit more, critically or from a different angle. And I just want to give you an overview first. So I'm going to give you a brief intro. Then I'm going to ask the question again, does psychedelic medicine need to reinvent the wheel? And then I would like to talk about basic principles in medical ethics and treatment. And I was actually going to use that to get more towards the treatment ladders, but I realized that this is actually something important to talk about, that I would really like to emphasize more today. Then I would like to introduce you to treatment ladders. Some people might know them already. They're ubiquitous in medicine, in fact. And then I would like to, dare to speculate. What could a psychedelic treatment ladder look like? And then just round it off with a few ideas. We are all aware that there are massively different positions, viewpoints, schools of thought in the discourse around psychedelics. From this emerging field of psychedelic therapy towards traditions in indigenous use, but also more recreational or self-developmental uses. And the position I would like to come from today is actually a pretty specific one. And to start talking about this, I brought this along with me for you. And if you see that, that's the first stethoscope I bought when I started working as a doctor. And if you now ask yourself why it's in German Schweinchen rosa, piglet pink, the easy question is I was working in a surgical department and a pink stethoscope was a sure way not to lose your stethoscope to one of your male colleagues without noticing. And I've bought better ones since, but this is kind of my one, and I really hold it dear because it has been with me for over a decade. So, a lot of times when we talk about how to proceed when we build psychedelic therapy and treatment, and we are wondering what to base our thoughts in. Do we really have to invent something completely new? There are many people who say the best way to go is root yourself in indigenous traditions, which I can acknowledge. There are very strong, very good indigenous traditions, but we also run into some problems there. How do we base psychotherapy in traditions that don't even have a notion of psychopathology in the way we have it, and no notion of psychotherapy in the sense we have it. And that's always been bugging me. And when I was having a conversation with one of my colleagues here, he said in this line, and I really thought this is clever, let's not forget, we are indigenous here. So we do have our own traditions of what accompanying healing processes is like. And even if in the last centuries, our European knowledge on how to work with psychedelics, especially mushrooms, has been lost due to, well, church politics and whatever, there is this tradition in the background. But even that doesn't really matter, because if we now come back to what Martha Havenit was saying in her first talk about how breathwork or psychedelic experiences bring people back or into the situation of having pivotal experiences. Eliciting pivotal experiences might be a new thing we do with this kind of therapy, but pivotal experiences, birth, death, accident, sickness, war, all these things have been with us forever, and there have always been people who were holding space and also trained to hold space in these situations. And even before Sigmund Freud bought his couch, it was physicians, general doctors, who just were there with their patients. And this is kind of my lineage. This is the tradition I come from. And if we look at it now, and think a bit from this point of view, it's just not true that there is no medical ethics. People have been talking about it for centuries, if not millennia. It starts with the Oath of Hippocrates. It goes via the Geneva Declaration. And I would like to talk a bit about some of the principles I find very important, like official ones, but then there's also those unofficial things that are being passed on among doctors that also can be helpful. But before I do that, I just want to point out, yes, with what we do here, we are standing on the shoulders of giants. But these are not giants of one kind, it's giants of many kinds. It's the indigenous traditions, it's our own philosophical tradition, and it's also our own healing and medical tradition. And I think we should really acknowledge that and take this into consideration as we move along. So, does psychedelic medicine need to reinvent the wheel? Just a few ideas of what to do with wheels in other contexts, and taking it from there, I would like to talk about the first set of basic principles in medical research and treatment. Who of you knows the Georgetown mantra? Some hands? Who's aware? Right, so the Georgetown mantra is a set of 4 basic principles in bioethics, biomedical ethics, that was set by Tom Beauchamp and James Childress in around 1977. They were both at Georgetown University. That's why it's called the Georgetown Mantra. And these are principles that are intended to guide how doctors interact with their patients. And they're pretty clear and simple on one hand, and on the other hand, they're not, because the implications go so far. Respect for autonomy. So the patient should be deciding about how he is being treated. This is what comes, for example, with the whole notion of informed consent. Okay, so far so good. But what happens when we take this notion into psychedelic therapy? How can somebody actually give informed consent to entering a psychedelic state when there is no comparable experience? Matt Johnson was kind of pointing that out nicely, how he's prepping his patients and really telling them also how difficult it can be and how far this can go. So we have to be aware, informed consent to something you can't even imagine is quite difficult to give. And what happens along the way, if we also try to keep this notion in mind during the therapy, where people are very regressed, very dependent, if you try to keep in mind this respect for autonomy, that might actually make treatment very different because you're not going into the guru-esque position. You're not the one who knows, but you also try to respect your patient's autonomy in this situation. And this is difficult to train and difficult to learn, because you really have to pull yourself out in the situation and leave the space for the person in the experience. The next two ones kind of sound like no-brainers, but again, they're not. So non-maleficence and beneficence. In Europe, we more go with the Latin term of nihil nocere, for do no harm. And again, this might look easy at first. Yeah, sure, you're not supposed to harm your patients, but sometimes, especially in ambiguous situations, how do you know what is harm? What is the bigger harm? In end-of-life situations, for example, I've seen that quite a few times. This whole dialogue about helping people die at the end of their side, so what is called Sterbehilfe in German. People have kind of pulled out the arguments and we have this notion of nihil nocere. We're not supposed to harm our patients. Ending a life would be harming the patient. Yeah, but if somebody is suffering unbearably, are we not doing him bigger harm by keeping him alive at all costs? Those are notions to keep in mind. And when we talk about psychedelics, we don't know if somebody is going to have a good or a difficult experience, if they be able to cope, if they will benefit. We can only react from our best intention, but that can go wrong. And this is something that we have to carry as a burden when we enter this kind of therapy. The justice debate, so accessibility, is a huge one in the psychedelic field at the moment. How do we bring therapy to patients? It's even more the case in the US, where people are not covered by health insurances. It's a huge thing. But again, it's not new. It's always been there. And it's not only for psychedelic therapies. This holds true for every kind of therapy. Injustice in access to therapy needs to be justified. And that's very hard. And money is in fact no argument, if you come from the patient's point of view at least, or a human point of view. Okay, let's move on. Those were formalized learnings. But then there are informalized learnings that I would like to come to next. And those happen kind of in that setting. You stand together with somebody with lots of experience, and they just teach by either storytelling or taking you along to learn. And just to emphasize how important also learning about difficult situations, pivotal states, is for everybody working there. Also the exchange among doctors and how to cope with very difficult situations is something that is very present when you do teaching younger doctors, students, and so on and so on. And I, interestingly enough, find myself also teaching about holding space in a very psychedelic sense when I'm talking to younger colleagues, or found it. I'm not doing it at the moment, but it used to be the case. And I just want to kind of, if some people are thinking, yeah, well, how can medical doctors' life situations be so similar to like really holding space in a difficult psychedelic experience? I can't imagine that. Right, Jamie, and if I was in America, and I'm not, I would give a trigger warning now, so those who want to take it, take it. I'm not giving it, but just telling you a story, how these things can go and what you need in this situation, and why also the tradition of already transmitting knowledge about how to handle difficult states is so important for doctors. I remember being on duty with the emergency doctors here in Germany. You drive out with a car. So you're with the paramedics going to the actual scene of an emergency. And the call we got was, in German, Kind aus großer Höhe, child from great heights. Oh, wow. You go there and you've got all things racing in your head, because the last thing you want to find is a broken 4-year-old on the pavement. And we arrive there and I see pink socks and I think, oh no. And then I walk closer, and it's actually not a child, it's an adult. But the person who put out the distress call was this woman's child. Because what had happened was that this lady was in her apartment on the 10th floor of an apartment block, and she had had a fallout with her partner the day before. And she told her 2 kids, aged 6 and 10, that she was doing them some dinner, went to the kitchen and jumped out of the window. Whew. so far, so bad. And as I'm standing there, while the police people are taking care of the kids, declaring this woman dead and like checking her out to be transported off, the second person the 10-year-old had called walks around the corner. The mother of the woman lying on the pavement, who lived two blocks down. So what she sees as she arrives is her daughter sprawled on the pavement beyond any help. This situation, sitting in the back of our ambulance with this woman, accompanying her through this primal pain of just untimely, unexpectedly, they were planning to go to the playground later, losing her child. This is holding space in real time, and not because sometimes somebody is on a substance and is going to get out on the other end. This is real life. And I think we should acknowledge that many, many doctors have encountered those situations, and we live with that. And this is one of the reasons why I think excluding medical doctors from this kind of therapy and treatment is a bit fast, because they actually have the expertise of centuries. Okay, but let's jump back to medical research and treatment basic rules to hospital ground rules. One of the most important, in my opinion, is pick people up where they are. So if you talk to a janitor, make sure the janitor understands what you're trying to tell him about his treatment. If you talk to a professor, make sure he understands too. And if you talk to a child, take this child serious and where this child is, and try to also take this child along to the point where you can take it concerning consent. I doubt that we are currently following this rule when it comes to psychedelic therapy. We're trying to drag people up to where we are. And this is a difficult notion. You know, all this talk about, you have to have a mystic experience, you have to have a transpersonal thing going. And also, even the music sets we're playing, they're mainly made by academics for academics, if we're honest. So I think if we really take seriously this point of picking our patients up where we are, we really have to get down and think again on how to approach all these topics. And if sometimes less is more. Because if a patient has to live up to kind of my expectations before I can treat him, this is definitely not a good step. Point 2. Never change a running system. IT people will agree with me. It's also true for medical stuff. If somebody has got working treatment for his mental disorder, not many side effects, and they're getting on well. No, we don't have to taper everybody off their medication and give them psychedelics. We should acknowledge that the existing treatments are good for some people. They're not good for others, and with those people we should work. But this is how this really comes together. And the third one, and I'm going to use that one to go into treatment ladders, is from non-invasive to invasive. If I hear about people now trying to turn 5-MeO-DMT into a therapeutic tool, I see somebody shooting at a sparrow with a bazooka. Okay. In medicine, just to give you an example of what I mean, from non-invasive to invasive. If somebody takes a fall and his knee hurts, the first step is not to amputate the leg. The first step is to give them an ice pack, physiotherapy, a painkiller, and then if it goes on, there might be an arthroscopy to look into the knee, and if things get worse, an operation or a knee replacement, and as an ultima ratio, the last thing you can do, yes, amputate the leg. And we're kind of not doing that with psychedelic medicine at the moment. We're not coming from less invasive things. I'm going to talk about what that could be, going towards invasive, but we're trying to hit once and hard. And if that is really the optimum for many patients is a good question. We have to work that out. Right. Treatment ladders are something that is used in many cases, and I've just told you the one about treating a knee problem. One of the medical ones that is very famous is the so-called WHO analgesic ladder for acute pain. So if somebody has acute pain, you start with a non-opioid medication. If that doesn't work, you add a mild opioid, and if that doesn't work, you add a strong opioid. If somebody comes in with a headache, you don't throw fentanyl at them. And you also keep the further step, the earlier steps with you as you progress along this kind of ladder. What could a psychedelic treatment ladder look like? Those who've been to Sergio's talk will get what I'm trying to allude to with this picture. I think we're talking about sand. So playing in the sand. We have like 4 kinds of things that can elicit altered state of consciousness, beneficial altered state of consciousness, psychedelic states if we want. We've got the serotonergic substances that we've been mainly talking about here. We've got the atypical psychedelics, among which I would count at this point ketamine and MDMA. We've got non-pharma methods that we also spoke about, like Marta's talk and a few others. And they're digital methods like the brilliant protocols that David Glowacki showed in his talk yesterday, where he showed that an intervention with virtual reality can really bring people high up on the 5DAC, so on the experience scale, to a level that he would have expected otherwise with around 100 micrograms of LSD, which is phenomenal in my opinion. And I would really like to learn more about that. Okay, so if we look at it, I'm not saying that every patient has to be taken from one step of the ladder to the next, but before we really jump in at the deep end, we should consider if this patient would already benefit from meditation and mindfulness. If active body-oriented methods like movement, trance dance, whatever, could be good. If methods directed at the body, like massage, heat, for example, sweat lodge, or body therapy, could be helpful, or something that gets more active and more intense, like breathwork, could be working for them. And if somebody already is much better after that, we might not have to go into the molecules at all, even if we'd like to. But we have to work out if it really makes sense. I'm not quite sure about the nitrous oxide and the cannabis. I think I would need to know more, especially the nitrous oxide on itself. I'm not quite convinced. But if we now look at the others, ketamine, MDMA, psilocybin, LSD, ayahuasca, DMT, and 5-MeO-DMT. I think in an ideal situation, we would prep people, for example, with meditation and mindfulness, have experience altered state of consciousness to do with their body, for example, through heat therapy, like sauna, whatever, sweat lodge, do breath work, and then proceed when they have understood kind of what it's all about. Because at the end of the day, it's not about the molecules, it's about the state of consciousness. And this is really important. That's also what kind of alleviates the burden of waiting for things to be handed to us by the authorities. We already have something to work with. It's not like we're standing there with bound wrists without any ability to move. We can do things already. Like, for example, and moving on, ketamine is accessible in many countries. In Russia, you kind of in a worse situation because they banned that for this kind of use. But in most European and in countries in the US, using ketamine-assisted therapy or ketamine-augmented therapy, like we do it, is possible. And then take it from there. If a patient needs more, for example, go into the psilocybin, and perhaps afterwards, if you need even a more peak-oriented, shorter experience, you could go further. And for me, the secret ingredients in whatever we do with psychedelic states, altered state of consciousness, is integration. Whether integration therapy, thank you, whether it is integration therapy, integration coaching, working by yourself, or being in a peer group. The experience is 10%, the integration is 90% at the end of the day, because it won't serve you if you don't integrate well. Right, so what I would suggest is, and we were having a conversation about this yesterday at our clinic too in the evening. Let's not, in preemptive submission to what we expect, for example, health insurances to expect of us, go for minimal viable models in time-wise and treatment-wise. But let's work out together what could be the optimal treatments for patients. What would be the best way, where to start, where to go, what to do. And once we've worked that out, let's look what a compromise, a good compromise, could look like. And I think perhaps things like the mindfulness, the body work, the breath work that can also be done in groups that are not very cost intense, can be stepping stones in this. And then offer good compromises also to the people who will have to pay for the therapies, and take it from there. I would really appreciate if we came to a point of view where we accept and see that this kind of therapy is on one hand new, on the other hand isn't, and that treating with pivotal experiences is basically human experience since the first days that we have had a consciousness. And that we should also take it from there and try to learn from as many different schools as possible and build a framework that allows for different perspectives, different approaches, and also different levels of consciousness in our patients to take them along and allow for better and, more precise therapies. Thank you very much.
Yes, Andrea bringing up ethical questions, Andrea bringing in the experience of a medical doctor in the field of psychedelic therapies. So we're up for questions from the online audiences and here from the hall. So please start by giving your questions. The gentleman here, yeah.
Thank you for your inspiring talk. I was wondering if in this model there is space, in your opinion, for low-dose therapy instead of relying so heavily on big experiences. Thank you.
That's a very important point you're raising. I think, again, picking our patients up where we are, there might be patients who need more sessions with lower doses, perhaps building up, perhaps not. And even though manualized and structured treatment models are great, altered states of consciousness are such an individual thing that we also should keep an eye on individualized therapies and really look for our patients' needs.
Thank you. Yeah. So, Hannah?
Yeah, thank you. So this example you shared around being in the pain of this losing a child, I found that really powerful. And it made me wonder how you can train or prepare for that kind of in-trauma moment versus the post-trauma moment. And from a medical perspective, how we can prepare doctors more to deal with these in-trauma moments.
The first step is getting acquainted with the fact that these things will happen. So the narrative has to be there. That's why it's so important that doctors, not daughters, doctors. I'm also a doctor's daughter, but never mind. So that it's important to share the narrative and make sure that people don't go into this field with overblown expectations also of how much they themselves can take. And somebody who helps should be able to ask for help. So having circles where people get together and share experiences and get support. And that's not done that much, actually. I spoke to my supervisor at that point, and he was like, okay, you think we need a Balint group? I'm like, yeah, I think we need a Balint group. And it was just not to be achieved in this setting. But I do think that responsible people in the field step up and teach this on an everyday basis. And sometimes it's just a few sentences every now and then to kind of break this kind of notion to people. And the other thing is, it's very hard to be prepared for the unthinkable. And then you just have to see how you cope. And I have to say, I think that psychedelic states can, in that case, be a great support for people to learn how to hold very, very strong emotions in any direction. So perhaps at some point it would be wonderful to have training studies also for emergency and intensive care doctors to prepare them for holding space for their patients using tools to elicit pivotal states named psychedelics.
We've got a question from the online audience about informed consent.
So we have a question from Sean, and he's saying, I'm not sure that the challenges that augmented therapies face regarding informed consent are new. For example, I think few patients ever understand what will truly happen to their body during surgery. Could you comment on how the challenges are different?
In most cases, during surgery, you're out of your conscience. You're not processing real time. And yes, the consequences of surgery doesn't go well can be life-threatening, difficult, and challenging afterwards, but living through the very moment is not quite the question. Usually can also be with like local anesthesia. It can be a different case, but not most really life challenging or life threatening operations are not done like that. And I think we are all, to a certain extent, used to difficult body experiences. We have all experienced physical sickness, but I think a challenging psychedelic experience is something you can hardly prepare somebody for with other life experiences.
Yes, the lady there, please. Yeah.
Hi, thank you for your talk. In the US, 80% of antidepressants are written by primary care doctors. And so as a primary care doctor, by training myself, I'm seeing that psychedelic medicine, once we have psilocybin available for depression and ketamine for depression, for example, the primary care doctor is not necessarily going to be trained to know which to refer to. So do you see a role perhaps down the line as for perhaps a subspecialty in psychedelic medicine so that there's somebody that these primary care doctors can refer to who has the knowledge to decide this patient would be better for this modality versus this other, and they may also be able to do the clearances that are the medical clearances regarding that are required for those medicines?
Here at the Mind Foundation, we are very strong believers in therapeutic teams, and what you're kind of describing is, to a certain point, a therapeutic team. In my opinion, already now, there should be like pods of GPs being able to work with a psychiatrist as a supervisor already. It will do miracles, in my opinion. If, for example, for every 20 general practitioners, there was one person they could call for support, that would actually be a huge step, because giving an antidepressant as a reaction to, I don't know what to do with this patient, is never a good treatment option.
Thank you. There are more questions from the online audience, please. Yeah.
So we have a question by Aaron. In terms of do not harm, how do you see psychedelics differ from psychiatric medications, which may have acute side effects but are still administered?
There are two treatment modalities that are not quite comparable. Yes, if you give somebody, for example, haloperidol, that might elicit side effects acutely, also chronically, as many antipsychotics. But usually, if you see there's something not going well, you can also just switch to other medication. Psychedelic experiences, even though they might be brief, if they are very challenging or very difficult to integrate or overwhelming, can leave a lasting trace on this person, far more, in my opinion. Do no harm also says try to do the lesser evil, but to work out what is the lesser evil in what situation is a hugely tricky task.
So, thank you. Lucas, please.
Yeah, also from me, thank you. That was a fantastic talk. I was wondering, so you presented this great letter of options that you have that you can take out, but I was wondering if you can say something about for which patients do you take out this letter? So are there people that you think none of these states are suitable for, or what kind of patient would you really use that for? Thank you.
Working out what patient will most probably benefit from being treated in altered states of consciousness is a conundrum that the field is still grappling with. I think most people agree that if you added a psychedelic, let's say, to the water supply down the hall, most people here would be able to cope with the experience, but there are also people in the world who might not be equipped to do well and learn from psychedelic experiences. The great thing is if you slow and then take your time to kind of climb up the ladder, you can check on every step if you're still with the patient, if you're still helping him, or where the actually tipping point is, where your treatment gets too disruptive, too invasive, too difficult. And for example, there are clear rules when you work with psilocybin, for example, that you would not include somebody who's has shown signs of psychosis in quite some time before that, or best ever in their life. But for example, starting with meditation, but let's not be mistaken. If somebody goes to a 10-day Vipassana meditation, that's what Elizabeth Nielsen says, they can come out in a very bad state if this doesn't go well. So let's not underestimate the non-pharma methods and so on and so on. It's always important to have an eye on your patient and to keep checking what's happening there.
Thank you. Let's take a last one. Yes, please.
Yes, also thank you for your talk. It was very inspiring, and I was wondering, it goes in the same direction. I mean, there's all this media coverage out there about like the breakthrough experiences, so I guess a lot of patients might just have, and this was also talked about, like these really high expectations coming to a person that might offer psychedelic assisted therapy, and how do you deal with sort of the resistance to start at the ladder, like lower down, I guess. And if it's like a clinical feeling of maybe it's not good to start at the top.
People that are very desperate want quick solutions. If somebody is in deep pain, be it physical or emotional, wants it to stop. But quick solutions can also backfire. And I think expectation management, talking to your patient, explaining why you want to go slow and why you want to build up to a certain treatment model. Most patients will understand, others might not, but it's important to keep that in mind. And as I'm saying, we're talking about autonomy. If a patient, there are cases where, for example, when we work with ketamine in the practice, where we find the patient too unstable to actually do that. And then we either offer other options, say, sorry, this kind of treatment from our point of view is not for you. Because there's a responsibility, autonomy and the responsibility you take if somebody can't decide. It's also an iffy point. And I just want to spend the last statement on hope. What you're talking about with the media coverage and so on and so on. There's all this, also the economic bubble that has developed, is feeding on hope. There are people out there who have tried a lot and they're very desperate, and suddenly there's something that gives them hope. And of course they're latching onto that, they're clinging onto this, they want this, and it's getting bigger and bigger. And this promise that the field seemingly is making, that these substances are safe, can be used well, and there is something to really be gained, is, again, as I said yesterday in the panel, people don't want complicated answers. Yes, but, no, but. People stop listening with the comma. And it's really important to keep that in mind. And also, as an intensive care or emergency doctor, I've learned to be very careful when giving people hope. Let me just finish this. When giving people hope, because if somebody who was desperate suddenly has hope and loses it again, the fall is even deeper, and I don't know if we will always be able to catch them in this fall. Thank you very much.
Thank you, Andrea. Thank you.